Ramsy Hunt syndrome, post-herpetic neuralgia, a persistent pain which is more variable in its character and severity than TN. It is typically persistent rather than paroxysmal transient. It affects old ages. Up to 10% of patients have trigeminal herpes zoster, therefore, diagnosis is directed toward the presence of facial scar or rash of the pervious attack. Treatment: it resists treatment including carbamazepin, anticonvulsants, Gabapentin, but use 200 mg of 5 times daily. Acyclovir, nerve of root resection, potent analgesic, mild to moderate relief. Transcutaneous electrical stimulation of the affected area by patient himself 5 to 10 minutes per hour, which lead to decreased pain potency through disturbing the sensory pain pathway. Anesthesia dolorosa. Following injury to the trigeminal nerve, a painful area of numbness may develop. This pain is severe and constant and described as burning, gnawing, or stinging. The most common cause is from destructive interventions for trigeminal neuralgia. Treatments: treatment of anesthesia dolorosa is often ineffective, and medications will often not relieve the pain. Surgical interventions that have been tried with limited success include focused injury to the brain stem, neuropathic pain secondary to other conditions, causes tumor affecting peripheral branches, pressure, malignant infiltration, intracranial neoplasm, aneurysms, Paget's disease, post-traumatic fibrosis, post-infection fibrosis usually accompanied by other deficits. Classic migraine headache. Migraine is an intermittent paroxysmal headache with pre-headache phase aura for free intervals caused by vascular spasm initiated by the release of endogenous vasoactive mediators such as serotonin, bradykinin, which lead to vasoconstriction followed by reflex vasodilatation. Causes: vascular theory, cerebral vasoconstriction, then reactive vasodilatation lead to throbbing quality of migraine and the relief of pain by ergots. Neuronal theory. The picture include pre-headache phase, VA family history, focal cerebral signs, visual aura, which is visual disturbance due to ophthalmic artery spasm, nausea, vomiting, photophobia, unilaterality. Moreover, there's a numbness, tingling, and intolerance to noises, phonophobia, osmophobia, aversion to sound. The symptoms last from several hours to 1 to 2 days. Female, male, age 10 to 30 years. Predisposing factors: emotional stress and anxiety, menstruation and hormonal disturbances, contraceptive pills, certain types of food, preservatives, liver, cheese and caffeine, alcohol, drugs, vasodilators, nitroglycerin, reserpine, antihypertensive, decreased blood sugar level and quat, hypoglycemia and quat. Treatment: Migral 1 to 2 mg, ergotamine 100 mg, caffeine, Cafergot 1 mg, ergotamine 100 mg, caffeine, Pazotfine 0.5 to 2 mg. Blockers and calcium channel blockers. Prophylactic for recurrent cases: 5-HT, 5-hydroxytryptamine, beta blockers. Mechanism unknown. Common migraine headache: it lack visual aura, produce more diffuse pain, non-differential pain. The duration and attacks are similar. The pain accompanied by altered sensation, nasal congestion, depression of salivation and lacrimation. Tension headache is the most common form of cephalgia, and it is precipitated by damaging emotional situations leading to muscle strain in the frontal and occipital region, just like a pressing band by lat band-like tightness. Precipitating factors: muscular tension, stress. The mechanisms are probably more complex, but stress, overwork, and depression are definite initiating factors. The bilateral pain is described as fullness, pressure, or tightness, with waves of superimposed aching. The typical throbbing sensation suggests a vascular component to the pain. Attacks may be acute with duration of few hours to a day, or in some instances the pain can be relatively constant for days or weeks. The tension headache is one of the few types of Sophalgia that can be constant and continuous both day and night on extended time period. Unlike migraine, nausea and vomiting are rare. Management: analgesics, NSAIDs, acetaminophen or aspirin, tricyclic antidepressants. Amitriptyline is the most researched for prevention, 10 to 75 mg, 1 to 2 hours before bedtime. Cluster headache. The attacks occur in periods clusters lasting for 4 to 6 weeks followed by long attack-free intervals. It is also called paroxysmal nocturnal sophalgia or migrainomatous neuralgia. It is caused by vascular changes at the base of the skull and abnormal hypothalamic function, in addition to edema and dilation of the wall of internal carotid artery and probably the external carotid artery. It affects men up to age 20 to 50 years in. Precipitated by alcohol or vasodilators, it comes spontaneously 1 to 3 times per day at the same time each day and may disturb sleep just like ringing of clock alarm. Summary of cluster headache. Clinical presentation: intensely severe pain, unilateral, periorbital, male predominant, several attacks 1 to 8, last for 30 to 180 minutes, regular times at night, alarm clock pain, nausea and vomiting uncommon, no aura, alcohol intolerance, autonomic hyperactivity, lacrimation, nasal congestion. Abortive symptomatic relief may be rapidly attained with oxygen inhalation. Subcutaneous sumatriptan is a very efficacious abortive therapy, but patients must be medically fit. Rapid transitional prophylaxis may be attained with corticosteroids that may be continued only for a limited period in selected patients. In both episodic and chronic CH, prophylaxis is usually with verapamil, and topiramate is second-line therapy. Chronic paroxysmal hemicrania. Chronic paroxysmal hemicrania (CPH) is a vascular headache disorder that is frequently confused with odontogenic pain (TMD) or regional pathology of structures of the face and head. It has features similar to migraine headache and may share some etiology and pathophysiology. Clinical features: CPH has a rapid onset and is associated with severe, consistently unilateral head pain lasting a few minutes to an hour. It differs from cluster in its high frequency and shorter duration of attacks, but they have numerous overlapping characteristics. Most often, the temporal and orbital regions are the site of pain, with the jaw and face also affected. Indomethacin in doses of 25 to 150 mg daily is effective in nearly all cases of CPH. In contrast to cluster, carbamazepin 100 mg tab 200 to 600 x2, Gabapentin, Neurontin 300 mg tab x3, pregabalin, Lyrica 100 mg tab 0.2 or 3 day, oxcarbazepine, trileptal tab 0.300 to 600 mg x2, amitriptyline, Elavil tab 0.10 to 100 mg QHS, nortriptyline, Pamelor tab 0.10 to 75 mg QHS, imipramine, tofranil tab 10 to 50 mg QHS, clonazepam 0.5 to 4 mg, doxepin 10 to 50 mg, duloxetine 30 to 60 mg, muscle relaxant for chronic OFP, baclofen, lioresal 10 to 20 mg, cyclobenzaprine 5 to 10 mg, Corisoprotol, Soma 350 mg, tizanidine, Zonaflex 350 mg, metaxalone, Scalaxin 800 mg. Miscellaneous conditions: temporal arteritis cause generalized inflammation with giant cell infiltration of the temporal artery. Clinical features more common in females in elderly, localized to temporal and frontal regions. Severe throbbing ache areas. Tender pain might be initiated by eating. Ischemia of mastication muscles. Vision might be affected due to retinal involvement. General sense of illness. Mandibular and lingual arteries may be involved. Pain in the Jaw or tongue may be early sign. Lab finding: increased ESR, anemia, abnormal CRP, biopsy specimen from artery. Treatment: 1. Systemic corticosteroids 40 to 60 mg per day. 2. Steroids immunosuppressive to reduce the complications. Miscellaneous conditions: auriculotemporal syndrome, Fry's syndrome, causes nerve damage induced by inflammatory, neoplastic pathology post-surgical. The auriculotemporal branch of TN carries sympathetic fibers to the sweat glands of the scalp and parasympathetic fibers to the parotid gland. Miscellaneous conditions: auriculotemporal syndrome, Fry's syndrome. Clinical features: recurrent episodes of localized facial flushing and/or sweating in the cutaneous nerve distribution area anterior to ear and on cheek. Pain, burning along nerve distribution, unilateral, provoked by eating food, taste or smell on touch. Management: no treatment. Full investigation of parotid gland. Eagles syndrome. Ossification of the stylohyoid ligament is a common idiopathic process which progresses gradually and is more pronounced among older patients. The ossification is usually revealed by panoramic radiographs of asymptomatic patients. Eagles syndrome is the combination of radiographic evidence of stylohyoid ligament ossification, elongation and pain. Suggestive features of psychogenic atypical facial pain. Women of middle age or older mainly affected. Absence of organic signs. Pain often poorly localized. Description of pain may be bizarre. Delusional symptoms occasionally associated. Lack of response to analgesics. Unchanging pain persisting for many years. Lack of any triggering factors. Good response to antidepressant treatment in few clinical trials. Muscular dystrophies. Muscular dystrophies, they are the most crippling disease of childhood. Weakness of muscles leads to progressively severe disability and is frequently associated with cardiomyopathy and respiratory impairment. There is no specific dental problem other than that of propping up a severely affected child in the dental chair. General anesthesia is dangerous. Cerebrovascular disease refers to disorders that result in damage to cerebral BV, leading to impaired cerebral circulation. CVA, or complete stroke, is a sudden impairment in cerebral circulation resulting in death or focal neurologic deficit lasting more than 24 hours. Neurologic events related to CVA include TIA, transient ischemic attack, a reversible acute, short-duration focal neurologic deficit, and quad mini-stroke and quad. Causes of strokes: hypertension, trauma, aneurysmal rupture, atherosclerotic and ischemia, thromboembolic events and occlusion of BV. Multiple sclerosis, MS. Multiple sclerosis, MS. 2 to 3% of patient with TN may have MS, but ages younger, less than 50 years, while older than 50 years must be TN. Pain is persistent rather than transient and lack of trigger zone in a way that it is indistinguishable from that of TN, and spread away and beyond trigeminal zone that is associated with. The disturbance in sensation depends on the brain site of the lesion. Paresthesia of lip. Extreme hypersensitivity. Pain diagnosis depend on the presence of multiple neurological deficits and disturbance of sensation. Painful eye movement, diplopia, optic atrophy, nystagmus, vertigo. Spastic weakness of leg, painful flexor spasm. Causes is unknown but genetic. Susceptibility exists. Autoimmune mechanisms causing demyelination, increased level of IgIN. Cytokines such as TNF are detected in CSF. Environmental or infectious agents, e.g. human herpes virus 6, HHV6, measles, mumps, rubella, para-influenza. Diagnosis: MRI, total protein mononuclear WBC in intrathecal. Increase. Treatment: glucocorticoids, IV methyl prednisolone 500 to 1000 mg for 3 to 5 days to manage initial attacks and acute exacerbations. interferon, IFN beta-1A and IFN beta-1B, and glatiramer acetate. Potassium channel blockers. Guillain-Barré syndrome. Guillain-Barré syndrome post-viral polyneuritis, an autoimmune disease due to progressive demyelination neuropathy after viral infection, characterized by paresthesia of the mouth and face, dysphagia, facial paralysis, ascending anesthesia and paralysis of leg and trunk. In severe cases, respiration is compromised and death happen due to respiratory infection. Parkinson's disease. Parkinson's disease. Decrease in dopamine level in CNS. The main features are slowness of motion called bradykinesia and muscular rigidity, especially in facial muscles, orofacial dyskinesia, drooling of saliva, loss of muscle control and speech defects, dysphagia, mastication difficulty, rhythmic increase and decrease in muscle tone in addition to mild stiffness in muscle of extremities. Pill rolling, which is the typical hand tremor movement. Neurological disturbances, facial nerve weakness, upper motor neuron lesions, muscles over the mandible and maxilla are weakened. Lower motor neuron lesions affects both the upper and lower facial muscles. Facial palsy, the UMN. Upper motor neuron lesion affects the lower part of the face while the lower MN lesion affects the whole of the face in the same side. The upper part of the face receive bilateral UMN from both cerebral hemispheres, whereas the lower part of the face LMN innervations only from the contralateral hemispheres. So facial palsy includes both UMN and LMN lesions. The causes are divided into extra and intracranial causes. Extracranial causes: Bell's palsy, parotid gland tumor, mostly malignant, complications of parotid gland surgery in which there is association of facial injury, misplaced dental anesthesia, Herefort's syndrome, which include sarcoidosis, parotid fever, lacrimal and parotid gland swelling in addition to facial palsy. Melkerson-Rosenthal syndrome, which is associated with median fissured tongue, facial swelling and facial palsy. In addition, the buccal mucosa has the cobblestone appearance. Intracranial causes: stroke, CVA, hypertension, thrombosis, hemorrhage, cerebral trauma, multiple sclerosis, HIV, post-herpetic neuralgia, trauma to base of skull. Clinical features: unknown cause, HSV, acute paralysis of the facial nerve, always unilateral loss of taste if the chorda tympani is involved. 50% develop pain at parotid and ear treatment. Most patients recover in few weeks. 60 mg prednisolone for 5 days plus or minus acyclovir 400 mg by 4 shade treatment. We should treat the actual cause. Acyclovir, Cevirax with or without prednisolone 20 mg 5 times daily. Note: if prednisolone is present, then the dose of it should be reduced during therapy. Physiotherapy, hot and cold pads, application and continuous massage to stimulate facial for eye which remain open, so ocular soothing eye drop and ointments. IV dexamethasone, sometimes anticoagulant, antihypertensive for CVA. If failure of all the above, then plastic surgery to create anastomosis between facial and hypoglossal and Alzheimer (S disease) AD, an acquired deterioration in cognitive abilities, memory, that impairs the successful performance of activities of daily living. Other mental faculties affected include problem-solving skills, judgment, visual spatial ability, and language. Etiology: neurotic plaques, amyloid. Genetic basis: autosomal dominant disorder with onset prior to age 65. Diagnosis: medical history, clinical and neurologic examination. CSF may show slight increase in the tau protein. Electroencephalographic demonstrate generalized slowing without focal features. Court MRI. Myasthenia gravis (MG) is a Chronic neuromuscular disease caused by autoimmune destruction of the acetylcholine receptor AAChR, disrupting cholinergic neuromuscular neurotransmission. Clinical manifestations: weakness of skeletal muscles, extraocular muscles and diplopia, eyelid drooping, weakness in the muscles of facial expression, masticatory muscles. Diagnosis: medical history, clinical examination, confirmation by serologic evidence of autoantibodies to ARCT, MRI. Treatment: anticholinesterase drugs such as neostigmine and pyridostigmine bromide, reducing autoantibody production using corticosteroids. Plasmapheresis to remove antibodies, high-dose